All right, this is management of patients with musculoskeletal disorders. Welcome, wonderful students. Location, severity, duration, characteristics, radiation, leg weakness are all assessments datas of patients with lower back pain. We have to look at how the pain occurred and how has the patient began to start to try to manage that pain, that lower back pain. What have they done? What medications have they taken? What over-the-counter medications have they taken? Have they used hot or cold therapy? Exactly what has been involved with trying to treat it on their own. We need to look at, is it a work-related injury? Is it recreational that led to it? We're going to look at the spinal curvature. We're going to look at the back, the limb symmetry, right? So we're going to look left, compare the left side to the right side, right? We're going to palpate the spinal muscles. We're going to see if there's any bulging discs. We're going to look at the patient's ability to move effectively with all of the actions of the muscles, right? We're going to have them bend, and we're going to have them flex, and we're going to have them abduct and adduct and all of those things. We're going to look at the deep tendon reflexes. How is the patient's sensation from head to toe? How is their muscle strength from head to toe? We'll look at their posture. How well do they change positions? How is their gait, right? All of these factors that can lead to back problems, right? Or exacerbation of that area. Again, we are going to nursing interventions that we use for lower back pain. We're going to do pain management, and that could be anywhere from Tylenol or a non-steroidal anti-inflammatory medication like Aleve or naproxen or something along those lines, or it could be something stronger like hydrocodone or Percocet or oxycodone, those kinds of things, right? We're going to have the patient do exercises too, right, to strengthen up those muscles. We're going to teach the patient proper body mechanics, right? We're going to do give them work modifications until we're able to strengthen that area and to develop it back up, right? We're going to teach the patient stress reduction tips because we know that when we're under stress, it causes additional hormones to be produced in the body like cortisol, norepinephrine, epinephrine, right? And when we live in that sympathetic nervous system environment all the time, that is not healthy, right? We're going to teach them health promotion, right? Things that they can do at home to promote having a healthy back, right? And we're going to teach them dietary and nutritional planning, and we're going to encourage weight reduction, right? If obesity or even being overweight at all, right? Because that is a factor that can lead to back pain and exacerbation of back pain, right? Okay, so here are proper standing, proper postures, and proper lifting technique. So when standing, keep these tips in mind that you're going to tell your patient. They're going to stand straight and tall with their shoulders back. They're going to keep their head level and in line with their body. They're going to pull in their abdomen. They're going to keep their feet and shoulder width apart, right? So they're going to have a strong, solid base. Tell them not to lock their knees, right? Because they can end up passing out if they lock their knees. They're going to bear their weight primarily on the balls of their feet. Keep their hands hanging naturally at their sides. We're going to follow these tips to avoid compressing the spinal discs and straining their lower back when they are lifting. Again, when lifting, we're going to keep a wide base of support. So the feet should be shoulder width apart with one foot slightly ahead of the other. So kind of in that karate stance, right? When the patient squats down, we're going to bend at the hips and knees only. If needed, we're going to put one knee to the floor as in the picture. Actually, I don't think she has her knee on the floor. My apologies. But if we need to, right, if they're not stable enough doing it like she is without putting a knee on the floor, we can put one knee on the floor to provide support, right? So you'll put one knee on the floor and then the other knee in front of you. The patient will put it in front of them, bent at a right angle. So kind of like half kneeling, right? Obviously, we want to keep good posture. So again, we're going to tell our patients look straight ahead, keep their back straight, their chest out, and their shoulders back. This helps keep the upper back straight while having a slight arch in their lower back. We're going to tell the patient to slowly lift by straightening their hip and knees, not their back. Keep their back straight and don't twist as they lift. Again, they are not going to twist as they lift. They're going to hold the load or what they're lifting as close to the body as possible at the level of the patient's belly button. They're going to use their feet to change direction by taking small steps, not by twisting the back. They're going to lead with their hips as they change direction. Again, keeping the shoulders in line with the hips as they move. They're going to set down their box or load, whatever they're lifting, carefully, and they're going to squat with the knees and hips only. Keep in mind, do not attempt to lift by bending forward. Again, they're going to bend their hips and knees to squat down to pick up the box, keep that box close to the body, and then straighten their legs to lift. They're never ever going to lift an object above their shoulder level. And they're going to avoid turning or twisting their body while lifting or holding an object because that can pull or strain a muscle. So never, never, never. Okay, nursing management with hand or wrist surgeries. Usually surgeries are performed in an ambulatory setting, in an ambulatory procedure. Many times patients will go to surgical centers for, same-day surgeries, basically. Patient education is a very big piece of nursing care for our patients undergoing outpatient surgeries. Again, we're going to do a lot of pre-op education, and then of course post-op education as well, but a lot of pre-op education, right, about what they're going to do post-op. Neurovascular assessment is critical and vital. Every hour for the first 24 hours, we are going to assess the patient's motor function. We're going to instruct our patients on the signs and symptoms to assess when they get sent home. Controlling pain is a big one. We're going to use medication. We're going to elevate the limb. We're going to intermittent ice, so 20-minute ice on, an hour off to the site, of course with the barrier in between. We're going to obviously do everything aseptically to prevent infection. We're going to keep the dressing clean and dry at all times. Wound care will be explicit in detail by the doctor, so we're going to educate the patient on how to do wound care, and we're going to have them show us, do a teach back, right? We're going to educate them on signs and symptoms of infection. So red, swelling, warmth, any kind of drainage, those kinds of things we've talked about in the past. And of course, we're going to assist them with their ADLs, right? And have them do as much as they possibly can safely, and then encourage their independence. But of course, help with the ADLs in the interim so they don't get hurt. Here are common foot problems. A callus is thickened layers of skin, often on the hands or feet, where friction repeatedly occurs. We have corns. They're thick, hardened layers of skin caused by pressure. Corns most often develop on the tops or sides of the feet or between the toes sometimes. They're benign and can also be found in weight-bearing areas. Again, they are hardened, raised bumps around inflamed skin, and they can be painful when pressed. So again, how do we prevent them? Wearing properly fitted shoes, using protective pads, maybe medicated patches, help remove existing corns, or even doctors can trim them off in the office. Okay, next is hammer toe. So this is a foot condition in which the toe has an abnormal bend in the middle joint. It's usually caused by wearing shoes, like women with high heels or narrowed toe boxes. So you know the toe box of a shoe. This could also be with men. If you wear one that's too narrow for your foot, it will cause a hammer toe. Okay, and usually the big toe, right? Because that's what's on the end, the distal part. And this hammer toe is going to be painful, hard to move, and usually develops corn or calluses over time, right? So again, wear roomier shoes, use sole inserts or pads, and to fix this, we may need, patients may need surgery. Ingrown toenail or onchocryptosis is a condition in which the corner or side of the toenail grows into the flesh. Again, it usually affects the big toe. People who have chronic comorbidities like diabetes mellitus are at greater risk of complications that get ingrown toenails. That's why we're always looking at diabetics' toes to make sure that they're having healthy feet, right? Because perfusion is less due to the excess, glucose in the blood, and extra plaque and other things that go along with having type 2 diabetes. But it's a higher risk. So again, we're going to look for pain, redness, swelling, because that can occur at the affected toenail. Lifting or removing the toenail can help, but antibiotics may be needed. So especially if the patient has a comorbidity that puts them at a higher risk for, infection. Next on the list is clawfoot. Clawfoot is a deformity of the foot. The joint of the toe that is closest to the ankle is bent upward, and the other joints are bent downward, so the toe looks like a claw. It could be like a congenital birth, something that was present at birth, or it could develop later in life because of other disorders. They could be caused by a nerve problem in the legs or a spinal cord problem, or it could be because of arthritis and over time. There are a lot of causes, right? Most of the time, claw toes are not harmful by themselves. Rarely, they may be the first sign of a more serious disease of the nervous system, but that'll be covered in Block 4, so we're not going to cover that here. Claw toes may cause pain, may lead to calluses on the top of the toe or over the first joint, but also they may be painless, right? And the condition may create problems like fitting into shoes and things like that. And then we have Hallus valgus, Morton neuromas, flat foot, so there's no curvature, and then plantar fasciitis. All right, so here's a picture of those different deformities. Assessment of patient foot surgery. So, surgery is usually an ambulatory procedure. Again, they go into a surgical center for like same-day surgery, and then we typically discharge them home. Patient education, of course, is a major nursing need for the patient undergoing outpatient surgery. We're going to do neurovascular assessments. They're critically vital every hour for the first 24 hours. We're going to assess motor function. We're going to instruct our patient on signs and symptoms to assess and report. We're going to control pain around the clock. We're going to give medications, elevation, intermittent, ice and cold. Prevention of infection is going to be one of the key components. We're going to keep our dressings clean and dry. Do wound care as prescribed by the provider. We're going to teach the patient again about signs and symptoms of infection. We're going to teach the patients about the importance of activities of daily living and getting assistance with their ADLs when they need help, but promoting independence the entire time. We're going to explore the need for home assistance, right? Because maybe the patients can't go directly home, and they need to go to a skilled nursing facility for rehab, or maybe they are okay to go home, but they just need some home health to help them with in the home. Let's see. We're going to give them very specific structural direction for when they're home. For example, how many distances required to walk every day, how many times a day. We need to find out if they have steps in the home, what that looks like, because we may put them on the bottom floor for a while and then advance them slowly. So it looks a little different. So let's get into this a little bit more. So again, nursing interventions for foot surgeries include, when we do our neurovascular assessment, we're looking at swelling, right? Is it the expected swelling post-op, or is it significantly more because there's a blood clot or something else that's going on there, right? We're going to look at the neurovascular every 1 hour for 24 hours, at least every hour for 24 hours, 1 to 2 hours. It really is at least every 2 for 24, but we say 1 because more thorough, and you need to be more, at least in the beginning, the first several hours, you need to be doing it hourly. Relieving inflammation, right? So we do that several ways. One is to elevate the extremity. So we're going to elevate the foot. We're going to use ice packs, 20 minutes on, an hour off. Going to give medications, anti-inflammatories. We're going to give analgesics, like pain meds. It could be over the counter in addition to opioids, because again, it's going to be painful, right? So opioids will be prescribed for approximately 5 days, and then along with over the counter like Tylenol and ibuprofen, right? Or NSAIDs. We're going to put the patient on weight-bearing restrictions based on the foot surgery, right? They're going to definitely be given assistive devices to use while they're regaining their strength, like crutches and walkers. And we're going to do all kinds of things to ensure our patient's safe, right? We're going to definitely do things to prevent infection, and we talked about all of these in our previous recordings. So really meticulous pin, wound care, again, keeping our dressings clean and dry, educating the patient on signs and symptoms of infection. All right, so next we're looking at is osteoarthritis. And these discussions, Marcel actually did a recording on osteoarthritis in detail. So I want you to make sure that you know osteoarthritis really well. And again, it is non-inflammatory disorder. It's degenerative in nature of the joints, and it is very common. And it is typically primary. There's 2 types, right? You have primary and secondary. Primary does not involve any type of autoimmune disease or inflammation, despite despite the rumor and old wives' tale that exists. It really doesn't. It can occur though as a result of an autoimmune disorder where the joint destruction occurs. So that can happen, right? And it's not systemic, right? It just is limited to the joints that it affects. So unlike rheumatoid arthritis, which is systemic, RA, rheumatoid arthritis, is systemic, meaning it affects both the left and right side of the bodies, right? Head to toe. And it affects the joints. Rheumatoid arthritis affects the joints, right? The synovial fluid in the joints, and that's why it affects all the joints. Well, osteoarthritis is not like that. It's limited to the joint that is affected, whether that's due to overuse of that joint, and that's why now you have arthritis, whatever that is, right? But it is limited to that joint. So again, the cartilage breaks down, leading to progressive damage of underlying bone, and then patients will develop bone spurs or osteophytes that protrude into the joint space and actually cause pain, right? Because the joint space is narrowed, you have that decreased joint movement, and then of course more potential for more damage to occur, and it just gets progressively worse and degenerates over time, right? And that's why we refer to it as like wear and tear because of aging, basically. There are many risk factors for osteoarthritis. Obviously, as we age, we're at a much higher risk of getting osteoarthritis, right? Again, osteoarthritis can cause pain, stiffness, and swelling. And in some cases, it can also reduce function and disability. Some people are no longer able to do daily tasks or even work, right? Signs and symptoms are pain, aching, stiffness, decreased range of motion or flexibility, swelling. And then again, risk factors would include older age, females that are higher risk than males, obese patients get it, right? Obesity, because the extra weight puts more stress on the joints themselves, particularly weight-bearing joints like the knees and hips. And this stress increases the risk of osteoarthritis in the joint. Obesity may also have metabolic effects that increase the risk of osteoarthritis. Certain occupations can also put the patient at a higher risk, like those requiring laborious tasks, right? Where you're overusing your joints, such as bending or repetitive stress on a joint, right? Maybe patients who engage in sport activities all the time, patients with a history of previous injuries, patients with muscle weakness, genetic predisposition, and certain diseases can also lead to osteoarthritis. The most prominent modifiable risk factor for osteoarthritis is obesity, right? Diet and exercise can help minimize this modifiable risk factor and can also help minimize symptoms of osteoarthritis in patients with obesity, right? Genetics is also a component. So people who have family members with osteoarthritis are more likely to develop osteoarthritis. There is a genetic component. And people who have hand osteoarthritis are more likely to develop knee osteoarthritis. Again, clinical manifestations: pain, stiffness, functional impairment, joint pain aggravated by continual movements or exercises that are relieved by rest. Morning stiffness is present, so they wake up with their joints already hurting and stiff. Usually brief, lasting less than 30 minutes, right? So as we start to use them, it's, a brief period. Onset is routinely insidious, progressing over multiple years. It affects joints, may be enlarged by, the affected joint may be compounded with decreased range of motion. Most often, weight-bearing, in the weight-bearing joints, like your hips or knees, or even your spine, right? Your cervical and lumbar spine, we use quite frequently. There is no cure for osteoarthritis. Treatment includes, again, increasing physical activity. And I want to say this, specifically weight-bearing exercises, okay? So physical therapy with muscle strengthening exercises. And then in addition to that, of course, we're going to encourage cardiovascular aerobic exercise. Lower extremity strength training is critical. So we're going to get occupational therapy involved. We're going to get physical therapy involved. We're going to get nutrition involved and have the patient lose weight if that's a factor, usually is. We're going to decrease the patient's pain and stiffness by giving them medications, including over-the-counter relievers, as well as prescribed medications we talked about. We're going to give supportive devices such as crutches or canes. We may suggest surgery if the other treatment options are ineffective. Definitely going to assess lifestyle changes, like how well does the patient use the mobility aids, the activity of daily living, as well as taking their pain medicine, right? We're going to assess their exercise ability, their strengthening exercises. We're going to do, our nursing assessment is going to be evaluating the patient's ability to perform their own ADLs in the home. We're going to inspect and palpate the patient's posture and gait and bone integrity and joint function and muscle strength and muscle size, all of those things, right? We're going to look at proper body alignment. Are the joints symmetrical? Are there any bone deformities? Is there inflammation, swelling, warmth, redness, tenderness, pain, discomfort? Because not only is pain exhausting, but also if prolonged, it can force the patient to become increasingly withdrawn and dependent on other people as their musculoskeletal disorder continues, right? And we don't want that. We want them to be independent. We're going to do patient education. Again, osteoarthritis pain may get progressively worse throughout the day, right? So we're going to teach our patients to plan activities that are extremely important to them, to do them in the morning when they feel the best, and also do like smaller increments of activity over time, throughout the day, and don't try to like slam everything in the morning. We're going to educate them on taking their pain medication, when to take it, how to take it, right? Especially if they're going to plan some physical activity, they want to take it 30 minutes before that activity. We're going to educate them on the side effects of these medications and how to deal with that, right? For example, if they're on opioids, we're going to tell them about the fact that opioids tend to bound up the bowels, and so they'll want to prophylactically take a stool softener and maybe, and definitely drink lots of fluids, right? Obviously, pharmacological management is going to be directed towards symptom management and pain control, and we're going to use that in conjunction with non-pharm measures to control pain as well, right? Stress reduction, all those things we talked about previously. Joint arthroplasty is joint replacement surgery, right, by an orthopedic surgeon. When there is, those arthritic joint surface changes, right? If there is severe joint pain or dysfunction, joint replacement surgery is an option. When less invasive therapies haven't worked, right? So we'll do that. Hemiarthroplasty replaces only the ball of the femur. Total ankle joint replacements are becoming more popular. The joint is fitted into the tibia and the foot. It has a plastic ball bearing that acts as a shock absorber, and it allows full range of motion, right? They'll put the incision in the anterior of the ankle. After surgery, we splint the ankle, and a bone stimulator may or may not be used. After about a week in the splint, the joint is casted for 8 weeks. Then a boot is placed, and the cast is removed, and then physical therapy begins, right? Sometimes, though, patients have to be in a leg brace permanently. Okay, this is a continuous passive motion therapy, or CPM therapy. It uses a machine to move a joint passively without the patient exerting any effort. A motorized device moves the joint repetitively to a set of number of degrees of the knee and a set movement speed, which of course is all figured out by the physiotherapist. CPM machines are most commonly applied to the knee, but there are versions of this for hips, shoulders, elbows, things like that. We commonly use them after joint surgeries to promote the recovery of normal range of motion and prevent joint stiffness as well as complications. Again, it's frequently recommended for knee replacements. Here is definitions of active and passive range of motions. We definitely discussed this in detail in lab. If you don't remember that, pause the video and take note cards. This information needs to be part of your permanent long-term memory. Total hip arthroplasty or hip replacement is a surgical procedure in which the hip joint is replaced by a prosthetic implant, hip prostheses. Hip replacement surgery can be performed as a total replacement or even a semi-replacement. Most common cause of chronic hip pain and disability is arthritis. Could be osteoarthritis, rheumatoid arthritis, or traumatic arthritis. Those are the most common forms of arthritis. Again, you need to know those: osteoarthritis, rheumatoid arthritis, okay, and then traumatic arthritis. Our goal is aimed at having the patient in the most optimal health prior to surgery, because the healthier the patient is, the quicker they will heal, as well as the better outcomes we will have, right? We need to make sure we look at all the risks and complications and manage them proactively. So, again, anytime we cut on a patient, there's bleeding risks. Other complications of hip arthroplasties include dislocation of the hip, prostheses. This occurs when the ball comes out of the socket. The risk for dislocation is greatest in the first few months after surgery while the tissues are healing. Dislocation is uncommon. If the ball does come out of the socket, a closed reduction usually can put it back into place without the need for more surgery, if done by a surgeon, right? A provider who knows what they're doing. In situations in which the hip continues to dislocate, however, further surgery may be needed. VTE or blood clots, right, in the legs, veins, or pelvis are one of the most common complications of hip replacement surgery. Again, blood clots in the legs, pelvis are one of the most common complications of hip surgery. Infection may occur superficially in the wound, or it could be deep around the prosthesis. It may happen within days or weeks of the surgery, and it can even occur years later, I've seen. That's not common, but it can. Minor infections of the wounds are generally treated with antibiotics. Major or deep infections may require more surgery and or removal of the prosthesis. Any infection in the body can spread to any joint, replacement surgery. Okay, so that, remember, the blood's moving through the body and through the bone marrow, the center of the bone, right? And if bacteria is in the blood, it's going to travel throughout all the body, all the organs, right? So it can spread that way. Another thing that's problematic is heel pressure injuries, right? And then something that's not on this slide that I thought of is the leg length inequality. So sometimes after a hip replacement, one leg may feel longer or shorter than the other. The orthopedic surgeon make every effort to make the leg lengths equal and even, but sometimes there may be just a slight variation in the length, right? So it may feel shorter or slightly longer and may affect the stability of the hip. So we got to make sure we're talking to our patients and interviewing them about that. And they may need a shoe lift after surgery if they feel like they need that for stability. We're definitely going to recommend it, right? Major goals before and after surgery include relief of pain. We want full functional ability, having a stable hip joint, right? And post-operative goals include getting the bones to it's heterotropic ossification, right? So heterotropic ossification is a diverse pathologic process defined as the formation of extraskeletal bone in muscle and soft tissues. HO can be conceptualized as a tissue repair process gone awry and is a common complication of trauma and or surgery. So I may have misstated this. We do not want HO, heterotropic ossification, right? So postoperative goals is to ensure that that does not occur because it can occur after surgical repairs. And trauma too can cause heterotropic ossification. But again, we want to prevent formation of extra skeletal bone, muscle, and soft tissue. Okay? Okay, so how do we prevent dislocation of the hip prostheses? The way we do that is correctly positioning the patient using a splint, a wedge pillow, and other pillows. We need to keep the hip in abduction, ABD, abduction, when turning. We need to keep the patient and hip in adduction when transferring. And we need to limit flexing of the hip, right? Less than 90 degrees. We need to be mobile and make sure we ambulate the patient. Patients usually begin ambulating on day 1 after surgery using a walker or crutches. And we want to do weight bearing as prescribed by the physician. And we might use a drain immediately post-operative for bleeding and fluid accumulation. And again, that's just typical bleeding post-op, right? So for up to 72, maybe 4 days, right? 72 hours, 4 days, up to 4 days. So 3 to 4 days. Abduction pillow. A hip abduction pillow is a soft but firm foam pillow that is placed between the thighs of the patient, and then we strap them onto the patient's legs while they're resting in this position. So you can see a picture of it here. These aid in keeping the patient stable and prevents them from crossing their legs and thus abducting motion that could definitely cause pain and injure, the surgical site in the hip. Next, we're also going to prevent infection. Again, we're going to remove the drain that's there to collect extra, blood and fluids. We're going to remove that drain usually within 48 to 72 hours. Unless there's excessive bleeding. We did talk about it could go up to 4 days. But as soon as the bleeding stops or slows down enough where it's not a problem to accumulate, we're gonna pull that drain out, because the longer it stays in the body, the higher risk that it can cause infection. We're gonna definitely clean our hands with soap and water, do strict hygiene practices when doing dressing changes. We're gonna keep in mind that a patient is at risk for infection up to 24 months. So they may be on prophylactic antibiotic, depending on the prescriber, for some time frame, right? Clearly, not being able to ambulate is going to put the patient at a higher risk for deep vein thrombosis. So we're definitely going to put the patient on any kind of prophylaxis therapy. We're going to have them with, the sequential compression devices, or SCDs, to move the blood flow. We might have them with TED hose on in the hospital. We're going to get them up and moving, sooner. We're going to have the patient, and we are going to monitor the patient for signs and symptoms of DVT and pulmonary embolisms we've talked about, right? And you need to know those signs and symptoms of DVT, all of the signs and symptoms: redness, swelling, warmth, tenderness, pain. When you measure the area where a DVT is at, many times there is enlarged girth because of this swelling due to the blockage, right? Now, be aware that there could be absolutely no signs and symptoms of a DVT. That does happen. But we are going to continuously monitor for them, because many, many times there will be some of those signs and symptoms. And then lots of education about the importance of rehab, getting up and moving, and committing to the rehab, right? Again, osteoporosis is the most prevalent bone disease in the world. We have more than 100 million, about 2 million orthopedic fractures each year. Normal homeostatic bone turnover is altered in these patients, and the rate of bone reabsorption is greater than the rate of bone formation in these patients, thus resulting in loss of total bone mass. Bone becomes porous in these patients, brittle, fragile, and breaks very easy under stress. Frequently results in compression fractures of the spine, fractures of the neck, fractures of the femur, Cole's fractures in the wrists, right? Again, many people are unaware that they even have osteoporosis until they get a fracture. And then when they go in to get care for that fracture, they find out they in fact have brittle bones, right? While the exact medical cause for osteoporosis isn't known, we know there are a lot of factors that contribute to osteoporosis, including aging, A sedentary lifestyle, so patients who have a lack of physical activity tend to have a greater occurrence of osteoporosis. Reduced levels of estrogen can lead to osteoporosis. We know there's a hereditary component. We know excessive use of steroids like cortisone can cause osteoporosis. Excessive use of thyroid hormones can cause osteoporosis. We know smoking is a factor. Excessive alcohol is a factor. Again, the loss of bone tends to occur most in the spine, lower forearm, above the wrist, and the upper femur or thigh. So we see what? Hip fractures, spine fractures, wrist fractures, right? They're the most common injury in older adults. Everyone inevitably will experience a gradual loss of bone mass, right? Generally beginning at the age of 35. After growth is complete, women ultimately will lose 30 to 50% of their bone density, and then men lose about 20 to 30%. Women lose bone calcium at an accelerated pace once they go through menopause, and that's why it affects women more dramatically. Menstrual periods stop because a woman's body produces less estrogen hormone. Again, which estrogen hormone is an important component of maintaining bone mass and bone strength, right? So you can see why women who are, after menopause are at a much higher risk. Here's what the bones actually look like. So the tissue in the middle is healthy bone tissue, but look at the osteoporosis there. It's just terrible, right? Weak and brittle. So again, the body constantly absorbs and replaces bone tissue with a healthy person. So again, the body with a healthy individual will constantly reabsorb and replace bone tissue. However, with osteoporosis, new bone creation doesn't keep up with the old bone removal. Many people have no symptoms at all until they get a bone fracture. And again, treatment includes medications, healthy diet, weight-bearing exercises, and then preventing any bone loss. All right. Here's what happens as a result of this bone loss and osteoporosis. We actually lose height. Goal of osteoporosis is prevention or slowing down the loss of bone strength over time to reduce the risk of fractures. Again, patients can strengthen their bones with weight-bearing exercises, lifestyle changes like no smoking, no drinking. Sometimes we can give bone strengthening medications like Fosamax. We also can improve muscle strength and balance, which can help prevent falls that will lead to fractures and disability. Again, with exercise, we're going to specifically include weight-bearing exercise. It is the most important type of exercise for preventing osteoporosis. The body supports its own weight against gravity, and the load of gravity on the bone activates bone cells to strengthen weaker areas. That's why it works. That is why astronauts can lose bone when they are in outer space, right? Because gravity has, there's much less force out there, right? So they're not having to build as much bone tissue up. Excuse me. Doing regular weight-bearing exercise after young adulthood can help prevent further bone loss and strengthen bone. It can also strengthen muscles and reduce the risk of falls. If patients have osteoporosis or osteopenia, there are some good weight-bearing exercises to try, like walking on level ground or a treadmill, hiking, using a stick for support if needed, walking in place in the corner of a room, holding the back of a chair to balance oneself, climbing stairs and using the handrails for safety, dancing, aerobics, lifting weights without straining their back. They can even lie down to protect their vertebrae. Sit and stand exercises. let's see, standing against a wall, sliding down with a slight knee bend, holding that position for 10 seconds, repeating that, right? Yoga, Tai Chi, again, lifestyle changes that need to happen. Smoking is a major contributor to osteoporosis. It acts directly on the bone forming cells by decreasing bone formation. It also contributes to poor nutrition by suppressing patients' appetite. It also affects estrogen metabolism and can even result in earlier menopause. It actually can also slow the healing of fractures. It's crazy how it impacts it, okay? And then limiting alcohol consumption. Again, not to exceed 1 daily drink for women or 2 daily drinks for men. Because drinking excessively increases the risks of falling and breaking a bone. Alcohol can fill patients up and also keep them from eating healthy protein foods that can contribute, and calcium, high calcium foods that can and vitamin D foods that can contribute to strong bones. Preventing falls, right? Because loss of bone strength increases the patient's risk for falls. Let's see. To help prevent falls, we're going to do all these exercises like we talked about, yoga, Tai Chi. They can do also, in addition to weight-bearing exercises, they can add non-weight-bearing exercises like swimming, biking, because that can also help strengthen their muscles and improve the patient's balance. So we're not going to just do weight-bearing. And if the patient has like more serious balance problems, they really should work with a physical therapist to do balance training and strengthening. And then we need to evaluate the patient's home to see if they have any kind of factors that can contribute to falls, like slippery surfaces, like floors or showers or icy driveways, those kinds of things. Loose rugs, right? Steps, stairs, bathtubs, tripping hazards like low furniture, cords, boxes, pets, you name it, right? Physician can evaluate whether the patient needs a bone density test. Early treatment for osteoporosis is the most effective way to slow down bone loss and prevent fractures. However, treatment programs after a fracture are also a value and may help to prevent future fractures. Of course, we're going to tell the patient to take vitamin and calcium and vitamin D together, because you need the vitamin D to regulate the amount of calcium that is taken into the bone. We're going to educate them on foods high in calcium and vitamin D. We may put them on an osteoporosis medication. Most osteoporosis medications do not replace the bone loss that a patient has already lost. However, they help prevent fractures and disability. What they do, most commonly used medications will slow down bone loss for the future, and they do that by decreasing the amount of bone your body is reabsorbing, which improves the bone remodeling balance in the skeleton. Okay, so I repeat that again because it can be confusing. So the most commonly used medication to slow down bone loss does it by decreasing the amount of bone the body reabsorbs, which allows and improves bone remodeling balance in the skeleton, therefore making the bone stronger. Because it protects the architecture of the bone from worsening, right? Right. So, biphosphonates, like Fosamax, slow down bone loss, improving the overall quality of the bones by allowing the body to build new bone at a rate closer to how quickly it is lost. So biphosphates, like alendronate or Fosamax, usually taken once a week. Typical dose is 70 milligrams. And it's important to educate the patient that they must remain at least upright for 30 minutes after taking their weekly dose, as it can cause esophagitis, which is inflammation of the esophagus that damages, that esophagus, the tube that runs from the throat to the stomach, right? So it's very, very important they stay upright for at least a half an hour after taking this medication. Another med that we might give them is calcitonin. This calcitonin pill is a artificial. What it is it's like the calcitonin hormone in the body, right? And the calcitonin hormone in the body helps control the calcium levels in the blood. Again, the calcitonin that we're going to take is usually in the form of a nasal spray, and it can relieve pain, right? Next is estrogen agonist or antagonist. We also have anabolic agents, not on this slide, but we have anabolic agents like a synthetic form of the parathyroid hormone. And those will stimulate the body to build new bone. Estrogen replacement therapy. Estrogen replacement therapy was once, back in the day, the only FDA approved treatment for preventing osteoporosis. Of course, that has changed, but estrogen replacement therapy, it's still an effective option for preserving bone mass and preventing osteoporosis related fractures in postmenopausal women, right? It's not appropriate for men or premenopausal women, okay? However, research has shown a link between estrogen replacement therapy and increased risks of breast cancer, strokes, heart attacks, blood clots, uterine cancers, some other health issues. Every other year, they'll say there is no link, and then the next year they say there is a link. So currently there is a small link between the two. We could get parathyroid hormone, or we could get a receptor activator of the kappa B ligand inhibitor. Okay. Osteomyelitis. Marcel again talked in depth about osteomyelitis, right? On the other recording, it's an infection of the bone. Remember, infections can reach bones by traveling through the bloodstream or spreading from nearby tissues. Infections can begin in the bone itself if there's like an injury to the bone, or if the bone's been exposed to bacteria that's traveling through the blood, right? Again, occurs because bacteria gets in there either through the blood or an extension of soft tissue. Or it could be direct bone contamination. It could be from a blood-borne spread from another site of infection, usually from trauma, right? And again, the causative agent or organism, pathogen, is bacteria. And this slide shows clinical manifestations of osteomyelitis, right? And we're going to use a negative pressure wound therapy, which of course will draw out fluid, infection, and air from the wound as it heals, thus helping it heal. A special dressing or bandage is sealed over the wound, and gentle vacuum pump is attached, which draws out the fluid, infection, and air. The application of negative pressure therapy is indicated for acute and chronic wounds. Promotes the healing of diabetic foot wounds, pressure ulcers, traumatic wounds, dehisced surgical wounds, partial thickness burns, flaps, grafts, you name it. We use them all the time. Again, it's going to remove excessive fluid. It's going to promote tissue growth and promotes blood flow. And it's going to remove air, fluid, blood, infection, all of it. Okay, this is the end of the chapter.